We now turn to a recent high-profile case of zoonoses, that of Ebola virus disease in West Africa, that illustrates the importance of understanding dynamics of spillovers and conditions subsequent to spillover. This is the worst Ebola epidemic in history, and as of October 2015 has accounted for an estimated 28,575 reported cases and has resulted in 11,313 deaths. Although current estimates suggest that the number of cases may have been substantially underreported by up to 70%. As we cover details of this case, keep in mind four important questions. What factors caused spillover? What factors caused epidemic? Why is this epidemic scientifically important? And why is this epidemic important to policymakers? I will begin by introducing some basic facts about Ebola virus disease. The disease commonly called Ebola, and formerly known as Ebola hemorrhagic fever, is now formally called Ebola virus disease, or EVD. It's a viral disease that affects both humans and non-human primates. Evidence suggests that spillover can easily occur when humans or other primates either eat the meat or eat other foods that are contaminated by the body fluid of a fruit bat who is a carrier of the virus. Fruit bats who carry the virus are thought to remain asymptomatic and never get sick. Once the virus has entered the human population, it spreads through contact with infected body fluids. One of the greatest human tragedies of the Ebola virus disease is that, because of the highly infectious nature of the body fluids of an infected person, the disease tends to spread most rapidly along the lines of love and care, among people who are caring for the sick and preparing the dead for funerals. Ebola virus disease is considered an emerging infectious disease. It was first documented by a Belgian scientist named Peter Piot in the context of two simultaneous outbreaks in 1976 that occurred in rural villages in the Sudan and the Democratic Republic of Congo, two countries in Central Africa. Ethnographic research suggests that local human populations throughout Central and Western Africa have long experience and knowledge of the disease due to sporadic, small-scale outbreaks that occurred historically and were not documented by scientists. Ebola virus disease in humans is caused by 4 of 5 viruses of the genus Ebola virus. The 4 that affect humans are Bundibugyo virus, BDBV, Sudan virus, or SUDV, Thai forest virus, or TAFV, and one simply called Ebola virus, abbreviated EBOV, and formerly called Zaire Ebola virus. Ebola virus is the most dangerous of the known Ebola virus disease-causing viruses and is responsible for the largest number of outbreaks, including that which led to the ongoing West African epidemic. The 5th virus, Ebola restin, or restin virus, abbreviated RESTV, is not thought or known to cause disease in humans, but has caused disease in non-human primates. The most effective treatment for Ebola infection includes early supportive care with rehydration and symptomatic treatment, which can improve chances of survival for a patient. There are currently no licensed treatments proven to neutralize the virus, and there are no licensed vaccines, though a number of vaccine trials are currently underway. The average Ebola virus disease case fatality rate is around 50%, but these can vary from 25% to 90% based on the strain, prior health of persons who become infected, and the availability of medical care. In the early stages of the disease, an infected person will typically develop a fever, a headache, joint and muscle pain, a sore throat, and intense muscle weakness. These typical flu-like symptoms are common in a number of infectious diseases, a fact which can complicate early diagnosis. These symptoms start suddenly between 2 and 21 days after becoming infected. As the disease progresses, these symptoms will be followed by diarrhea, vomiting, a rash, stomach pain, and impaired kidney and liver function. The patient may then begin to experience hemorrhagic symptoms, meaning bleeding internally, and may also bleed from ears, eyes, nose, mouth, and other bodily orifices. If the infected person dies, it's usually due to a combination of dehydration and low blood pressure. Although a number of countries have reported cases associated with this Ebola virus disease outbreak, The three most affected countries are Guinea, Liberia, and Sierra Leone in West Africa. The initial spillover event that sparked the epidemic occurred in the village of Meliandou, located in a rural area of Guinea that is nonetheless characterized by porous borders amidst dense international migration and trade networks. The origin of this particular outbreak is traced to the likely confluence of a virus, a bat, and a 2-year-old child, and then an under-equipped rural hospital. In March of 2014, health workers in southeastern Guinea alerted public health officials and Doctors Without Borders of the first clustered cases of an unknown infection with a high incidence of mortality. Eventually, the infection was found to be caused by the Ebola virus organism. This picture shows a photograph of the village of Meliandou, which is surrounded by forest created over the years by people who live there and includes groves of fruit trees and agricultural areas. The first human case in this outbreak, a child named Emile Wamonu, who has come to be known to most simply as Patient Zero, is believed to somehow have come into contact with the body fluids or excretions of an infected fruit bat in late 2013. Recent research shows that this likely occurred while he was simply playing in an area where several species of bats had been observed roosting. From Emile, whose grave is shown in this photograph, the infection spread to family members who cared for him. His mother, grandmother, and older sister also died. The disease began to spread quickly in the village and in surrounding villages. Symptoms recalled include fever, vomiting, diarrhea, dehydration, and bleeding. The infection was soon passed to staff of a local health center. Few diseases in recent memory have inspired the level of surprise, fear, and fascination as Ebola. For most of the crisis, the international media has offered the public various versions of a seemingly common sense but highly misleading story. We're asked to visualize rural Guinea, where the outbreak suddenly and spontaneously began, an apparently degraded rural landscape in which savanna has replaced most of the lush, humid forest that we are told once blanketed the region. We're told that extreme poverty, breakdown of traditional forest management practices, and unsustainable livelihood activities drive members of a rapidly growing population to burn and clear once expansive humid forests for cultivation of staple crops and extraction of non-timber forest products. To augment lean diets and lean incomes, impoverished people, we are told, encroach further and further into the once pristine wilderness in search of wild sources of protein, bushmeat. In this case, a species of Ebola virus likely carried by a wild bat infected a human child, and then spread rapidly once it entered the setting of a rural healthcare facility and later urban environments. In an increasingly connected world, we are warned, local spillover incidents in distant locales threaten to become global outbreaks that endanger international health and security. An infected person, animal, or box of smuggled bushmeat, as the magazine Newsweek claimed in their 29 August 2014 cover, could travel from rural African hot zones to the centers of global power in a few short hours or days. This story that I've just told is what Patricia Wald, a scholar of scientific and medical narratives, has termed an outbreak narrative. It tells us how the worst Ebola outbreak ever began in West Africa and how it overwhelmed health systems and the efforts of the international community. Much coverage has incorrectly emphasized local poverty, cultural practices, deforestation, and bushmeat consumption as primary causal factors in the zoonotic spillover and ongoing epidemic. Unfortunately, the ways in which these factors are incorporated into the outbreak narrative paints an overly simplified and actually false picture of what happened. And in addition, it lays primary blame for the crisis at the feet of those most tragically affected. Inaccurate assumptions about human-environment relationships and insufficient understandings of environmental change have influenced public misunderstandings and have informed top-down development interventions that may have themselves compromised resilience and exacerbated the severity of the outbreak. A number of known facts contradict the dominant Ebola narrative. First, Ebola in West Africa was not surprising considering the evidence available, even though it's frequently depicted as a surprising, sudden flare-up. Deforestation is not occurring in the region of spillover. Residents of many rural communities in southeastern Guinea, including communities in the area in which the spillover occurred, are not cutting down old-growth trees to plant food crops. Rather, dominant local land use patterns involve agroforestry practices that actually promote the growth of dense vegetation, often called forest islands, interspersed with fruit groves, food crops, coffee, cola, small palm oil patches, and fallows. These forested islands surround villages and areas where dense forest vegetation does not naturally occur. Wild game hunting is not a driver of this crisis at all. Bushmeat is not associated with spillover. After one spillover event, that which resulted in the death of Emil, all other cases in this epidemic were transmitted from human to human. Many precise details surrounding the ecology of Ebola and the circumstances that led to the current outbreak remain uncertain. However, evidence from a growing body of research in a number of fields by ecologists, epidemiologists, anthropologists, environmental historians, development researchers, physician researchers, and journalists indicates that important parts of the outbreak story that we've just mentioned are inaccurate or incomplete, including assumptions about underlying local-level human ecological relations. Considering this evidence, we must closely examine how historical and political processes might bring humans and viral hosts together, increasing opportunities for spillovers to occur. So, casting aside assumptions and stereotypes, what are important facts to consider? The common impression that the spillover that gave rise to the outbreak in West Africa was spontaneous or without warning is questionable. Over a decade of serological research indicates that fruit bats are likely a common asymptomatic reservoir of Ebola virus, and that they have an incredibly extensive migratory range that includes southeastern Guinea and other countries in West Africa. Tests of human blood samples collected in Sierra Leone, Liberia, and Guinea between 2006 and 2008 from patients with suspected Lassa fever, but who tested negative for both Lassa virus and malaria, found that 19 cases, or 8.6% of 220 samples, tested positive for Ebola Zaire antibodies. Taken together, these data indicate that the same species of Ebola virus implicated in the current outbreak was present in bat populations for at least 10 years in the region, and in human blood samples collected at least 5 years prior to the spillover associated with the current epidemic. As we can see, Ebola virus has been present in the environment, and periodic spillovers have occurred in affected parts of West Africa for quite some time. Land use changes associated with development activities can result in large-scale ecological shifts that can increase the risk of zoonoses. The primary drivers of environmental change in contemporary West Africa involve expansive land grabs, encouraged by generous reforms designed to attract international investment in large-scale export-oriented mineral extraction, timber extraction, and agribusiness activities, especially palm oil production. Oil palm is one of the world's most rapidly expanding cash crops, in large part due to its use in producing biodiesel. Regional land grabs for oil palm plantations are likely implicated in massive ecological perturbations associated with ecological phase shifts that result in increased risk of disease spillover events for rural communities. While land grabs in general disarticulate people from their homes and livelihoods, land grabs for plantation agriculture also reshape the ecological system dynamics and can reduce biodiversity by causing habitat fragmentation. This can also include the habitats of wild bats, which must then adapt to a rapidly changing ecological landscape. This in turn affects adaptive changes in bat demography and behavior, especially migratory and feeding behavior. One result is larger than normal populations of wild bats migrating from across the region to attractive anthropogenic local landscapes and forest patches containing plentiful cultivated fruits, insects, trees, and other dense vegetation for roosting. This places more bats in closer proximity with one another and with livestock and people, increasing opportunities for viral amplification and cross-species transmission. Throughout the West African Ebola epidemic, the international media and policy responses, for example banning bushmeat, remained disproportionately focused on the conditions of spillover, despite the fact that, with the exception of baby Emil, each of the thousands of later incidents of transmission occurred through human-to-human contact, primarily in hospitals and homes and surrounding the burial of the dead. So we must ask, what particular factors have caused the epidemic to escalate to the extent that it has? The Ebola crisis has exposed the consequences of patterns of systematic underdevelopment and structural violence, as well as the implications of deep-seated unequal global social and economic relations. Structural violence occurs when social structures and institutions cause harm by preventing people from meeting their needs, by excluding people from opportunities, and by focusing disproportionate risk on particular groups of people and not others. For many years, the West African region has suffered the consequences of structural adjustment and economic reforms pushed as a condition for international aid. This has resulted in the hollowing out of states and the decimation of public services, including health systems. Shifting service provision to the private sector and failure to train professionals and support state capacity in health and other services in turn has compounded this. We must ask whether the Ebola crisis is in large part the result of failed development, and indeed systematic underdevelopment and inequality entrenched by development policies imposed by powerful countries. In West Africa, active neglect has surely been a contributory factor to the devastation being wreaked by Ebola. Furthermore, the lack of functional surveillance and lack of ability to cope in the formal healthcare sectors in affected countries is intimately related to broader political and economic trends. In recent years, regulatory changes and dramatic increases in regional land grabs for development activities, for example, have benefited international investors and national political elites. Yet the costs of these activities and political rivalries that arise around them are disproportionately borne at a local level. In this case, development is not manifested in benefits to human development, such as improved labor conditions, economic and social opportunities, reduced corruption, increased equity, or improved public health and public services. At the same time, these activities have contributed to environmental and economic transitions that could have exposed rural populations to increased risk of exposure to deadly diseases without sufficient means to cope. A result of these processes, cumulatively, is a lack of resilience to crises due to a lack of capacity to respond to emergencies, decimated public services, gutted health systems, and a pervasive atmosphere of mistrust across communities. These salient historical factors compound what social scientists have identified as a number of key factors that interacted to create an environment in West Africa in which the Ebola epidemic could flourish and response efforts were compromised. As Ebola virus disease spread rapidly, rumors and misinformation, including those spread by governments and NGOs, have resulted in widespread misunderstandings around the causes of the disease and effective treatments. Identifying and diagnosing cases was difficult for a number of reasons, including insufficient capacity for laboratory work, insufficient capacity for collection and transport of biological samples, and insufficient capacity for data management and reporting. Quarantine measures and curfews were resisted because for many households, they were detrimental to livelihoods. Migration away from centers of infection also contributed to the spread of the disease. Caring for the sick has been a particular challenge due to a shortage of hospitals, beds, ambulances, and trained medical staff, as well as poor decontamination and sanitation capabilities. A result of this is not only poor capacity to care for those infected by Ebola virus disease, but the fact that people not suffering from Ebola cannot be cared for in formal facilities. Caring for the dead has presented further challenges. Mourning families have been blamed for the crisis, and official medical burial teams have been resisted, and cemetery space has been insufficient. Throughout the crisis, there's been a need for medical burial teams not to just be sanitary, but to also be respectful and trusted, and this has been a persistent problem. These factors have led also to social stigmatization of survivors and their families, and this will present substantial civic challenges going forward. In the context of the Ebola epidemic, international response coordinators learned far too late that community engagement is the key to successfully controlling outbreaks. Lack of community engagement, widespread mistrust of medical teams, international agencies, and public health messages could have been avoided with early and respectful efforts to involve communities in the response. One of the major lessons that's been reinforced in the context of crisis is that good outbreak control relies on applying a package of interventions, namely case management, surveillance, contact tracing, a good laboratory service, safe burials, and respectful social mobilization. Taking these lessons into account, important areas of research for scientists going forward include understanding dynamic relationships between political economic forces and ecological change, determining precise dynamics of viral transmission between wildlife and possible insect vectors, identifying concretely whether there have in fact been previous spillovers of zoonotic diseases in different regions, including West Africa, that have resulted in small rural outbreaks unnoticed by the outside world, and if so, asking how affected families and communities were able to mobilize knowledge and resources to identify and respond to them. Coordinated ecological and epidemiological surveillance activities integrated into functioning basic public health systems may not have prevented an initial spillover in the case of Ebola virus disease in West Africa, but could have allowed countries affected by the crisis to remain a step ahead in terms of knowledge and preparedness. This case highlights how the convergence of policies, people, animals, and environment has created a new global dynamic in which the health of each is inextricably interconnected. Further questions raised in the context of the current crisis point to important work ahead involving coordination among researchers, international donor organizations, governments, and members of local communities. It should also involve building collaborations across sectors and scales, involving agricultural, environmental, and health sectors, as well as policymakers, donors, practitioners, researchers, and communities.